So I'd like to open it up to questions from the audience. No question, guys. Not a single one. Okay, I guess I have a question for Dr. Schultz-Watt. What was the technique that you used just at the end when Janet had that kind of emotional reaction? Because it had a very calming effect on her, and clearly she was in quite a lot of distress. So I think this is something that we get commonly, is that when patients get overwhelmed and upset by recounting their very difficult journey, it's often helpful to have someone be there and listen. So what was that technique there?
I'm not even so sure whether I was using a technique as a manipulation. I think I felt strongly that there was a need for proximity. And I think it goes back to the idea of attachment theory. We get thrown into this world without a contract signed. We don't know what's going on, and we have to somehow make it work. And if we have significant others, typically our mother and father, but not in every case, who are there for us and who do it in the right way, letting us make mistakes, but also making sure that we have enough support and safety and a sense of bonding, then we will grow up as securely attached human beings. And some of us don't have that benefit, and we will be more anxious or more avoidant or more disorganized in our attachment. And right now, I think this was a very classical example of a securely attached person being able to express her emotions, but just needing someone by her side.
Thank you for that. Thank you. I think we have some questions from the audience. Sheehan? Yeah.
Thank you. A couple of questions from the virtual attendees. Iris says, what can we do as former caregivers to help those who are here now?
So I think the question is a broad one. So I do know this person that's online, and she did lose her partner to stomach cancer, unfortunately. So the question really is, knowing her story a little bit, I know she felt supported at the time when her partner was unfortunately passing away. But now she feels maybe like she's left behind. So is there any advice or any supports or resources for caregivers that have unfortunately lost their partner? And it's open to anyone.
As far as caregivers who have lost their partners, we've had that in our group. And staying in the community, I know helps some, and I know leaving the community helps others. So it really depends on what is best for them. If you feel you have that caregiving heart that just keeps going, and it doesn't matter who it is, but you want to keep caring for people and letting them know they're not alone, staying in a community is great. Just being supportive and letting everybody else know that they're being loved and they're understood.
I might want to second this and say, Breffney and myself working, in the cancer center, we very often experience the situation that actually, and there's good evidence out there in the world from an evidence literature perspective, that actually caregivers are the ones who are losing much more a sense of meaning through the loss of a patient than patients are losing meaning. And this is something we are, unfortunately, at this stage of our healthcare development, not really good at addressing and buffering. There is a very famous poem that in palliative care and hospice care we often recite in this context from Masha Kaleko, and I'm not going to do the whole thing. I just wanted to say the one line which I think is really speaking to the phenomenon that this colleague of yours, a friend of yours, is addressing, and that's the idea that one's own death, one dies only, but the death of the other one has to witness and to live with. And I think that is the very moment that needs to be addressed more through good grief therapy. And I think that's the one thing I want to give away as a concrete specific moment. In the communities here in Canada, there are very strong grief support networks. And maybe this person should be reaching out via the Grief CA website to see which community specifically focuses on caregiver grief support.
We have
Oh, Dr. Hannon, sorry, did you have something to add to that? Okay. Cheyenne, there's more? Yeah.
a couple of questions around fertility. And this person, Mahathi, says, for Doctors Ripley and Patrantonio, can you speak to a little bit about how immunotherapy may impact fertility and menses? And someone else said, also around fertility, I want to have a baby, but I'm in my 30s. I've just been diagnosed. How long does fertility preservation take? I don't want the cancer to spread.
There's a mic.
Is this on? Oh, yeah. I think it's on. Perfect. To answer the second question first, just because it's a shorter answer, typically, like for females to do fertility preservation that involves like an egg retrieval and then either egg cryopreservation or embryo cryo, typically takes about 2 weeks or so. So you also kind of have to factor in, like, the patient still needs to be seen in consultation. Typically a couple of tests can be quickly done and then the cycle itself starts. So I would say start to finish, the patient should be able to be done their treatment within sort of 2.5 weeks or so at the most. Obviously for men, it's significantly quicker. They can usually preserve their fertility within a couple of days of the time that the clinic is contacted. The first question was about biologic agents and fertility. Sorry, immunotherapy. Sorry, did you want to?
Yeah. I think that we have no data today to state that immunotherapy may negatively impact on the fertility. Only problem is that this treatment is usually associated with chemotherapy. So the rules and the data we have for chemotherapy are valid for patients that are receiving chemoimmunotherapy at present. Anyway, for specific subgroups, such as those patients with microsatellite instability, we will probably go for omission of chemotherapy and immunotherapy-based treatments. So this will be a particular subset with no big issues for fertility preservation.
Yeah, I was just going to say, I actually looked in, I sort of anticipated that question and had looked into it prior to making the talk. And I did have a couple slides on it, but with time constraints and stuff, I didn't put it in. But like you said, I mean, there's really nothing, there's no good data on it whatsoever, which is problematic in the obstetrical world, but not a surprise, because women are often, women who are pregnant are often, it's a universal problem that they're often excluded from sort of drug trials and that sort of thing. So, this is probably data that we'll never have. There's also questions, what if somebody conceives while they're on these medications? And again, because we just don't have the data out there to really know. So unfortunately, there's not really an answer to that question.
And thank you. We have another question for Dr. Annan, I think. If I receive palliative care in hospice, will I be able to see my oncologist? Do I have to stay until I die, or can I go and come? I'm nearing end of life and I'm scared. This is from Anna in Manitoba.
Thank you so much for that question. Anna, as I was saying in my talk, palliative care can occur in lots of different places. So it can occur in the home, in the hospital setting, or as you say, in a residential hospice or palliative care unit. Now, depending on where that is, some palliative care units are within acute hospitals. So at the Princess Margaret, for example, we have a palliative care unit in the cancer centre. And in that situation, the oncologists certainly come by and see their patients, although, of course, most of the patients are not actually having active treatment at that time because they're simply not well enough to tolerate it. And in other, if it's a residential hospice that's not on the site of the hospital, it's different, and it may not be that your oncologist will be coming by or seeing you regularly, but that would be up for discussion with the individual institution. Some patients certainly come and go, and when they're feeling well, they're able to go out. Obviously, it was different during the pandemic, but thankfully that has improved a little bit again. And really, the most important thing is that you're getting the care in the most appropriate place. And whether that's your home or the hospital or a hospice or palliative care unit, your team is going to work really, really closely with you and your chosen family to make sure that you're getting the care that's right for you at the right time and with the right people involved.
What would be the correct way to give support to a family member, I guess, with this disease? Talking about emotions, movements, etc., more like the day-to-day. And this is Martin Canales.
How to best support a patient day-to-day as a caregiver?
I mean, it's probably actually a question for the two of you.
I can.
Please, yes.
And then I have a question for you. Is that allowed? Can a panelist ask a question? Okay. I wrote my own book, but then I was asked to be a contributing author on a caregiver's book. And so I was asked to write a chapter to give advice to caregivers from a patient's perspective, which is really unique. And I think my answer to this would be to ask the patient. When I looked back at my experience, I don't think any of my friends or my family ever asked me what I wanted and how I wanted them to speak to me. So I think that's a very difficult thing to do, but to have that raw conversation and to also know that it's going to change from day to day, I think, and week to week. And as a patient going through a journey, there's days where we're feeling awesome, and then there's days where it's not so good. So I think to take those cues from the patient and help them guide you through how to be a caregiver. That's just my opinion. I don't know, Janeth, if...
Yes, I agree. I wish somebody would have asked me. But again, my bubble during the pandemic was very limited. So it was a little easier to control as to who was coming in and out. It was more of the guidelines of what was safe for me. But just making sure that you're heard, and I guess it's the more people need to learn about toxic positivity. Because you don't feel heard, you don't feel seen. Everybody's like, oh, you need a positive attitude. Well, just because I'm scared doesn't mean that I don't have a positive attitude. Like, there's a lot to fight for, but those are just my feelings at that moment. You just want to be validated because you're the one going through it. But I think it's also that the caregivers need to share honestly how they feel. Because I've seen a lot of times that the caregivers and the patient aren't on the same page. The caregiver wants to push for certain things, and the patient is tired and doesn't want to do certain things. So it's about both of them understanding each other, how they're feeling, and what they want.
Yeah, I want to add two things here from my own experience. It's always important to keep in mind that in the vast majority of cases, we are going to have a situation where the caregiver and the patient at the same time are experiencing this for the first time in their life. So no one has a playbook to work from, but rather everyone is basically driving towards the horizon without knowing actually what the road's looking like. And with this comes naturally situations in which we're not aligned, where the caregiver wants, as you say, one thing and the patient wants another thing. And many patients and caregivers have not learned how to talk about really intense, complex emotions and might not even have the language for it. So maybe one aspect as a concrete, specific suggestion I would make is to maybe start sitting together relatively early at the beginning of a trajectory and making time for regular, recurring meetings in which you learn to listen to each other. And this goes both ways. This can be once weekly, once monthly, but almost developing a little bit of a ritual where we say, you know, is it time for a ritual again? Do I just need to sit down with you and listen for 10 minutes, no matter what you're going to say? I'm just trying to really listen. And then you can share with me. And then afterwards, I want you to really try and listen to what I have to say. What do you think? How does that sound?
Oh, Teresa has a question. Go ahead.
I have a question, and probably it might be the last one, only because I think we have to do one quick final presentation. But in the work that we do, survivor's guilt is just comes with the territory. It is incredibly difficult, especially when you're you're grateful to be 11 years out. But then when I look back and I realize how many people we've lost, or in a year like this year where so many of the patients that passed away were very young, for me, it's been a very difficult year of dealing with that survivor's guilt, because I just feel like there's an imbalance there, and that's really hard. And I'm asking maybe you, Christian, and maybe the other survivors that are here. It's like, for me, it's just been particularly difficult over the last few months, and possibly because we've had a lot of people pass away and a lot of young people pass away. And I thought I was always young when I was going through it. So it's just, I don't know how other people deal with that. And I know that partners that lose, you know, their other partners also have that survivor's guilt, as do parents that lose children, because we talk to a lot of parents, and it's just such a difficult thing to deal with. And I don't know if anyone, you know, Christian, if you had some helpful words.
I'm going to come from the existential perspective. As you say, it comes with the territory, and survivor's guilt will always be there and will always feel very bad. So addressing it, taking it for what it is, and not trying to positively reframe it, using positive psychology to a point. Positive psychology is helpful, don't get me wrong, but it can reach a level of toxicity where it actually silences you. You, Teresa, are courageous for speaking up about it and articulating it. It is part of your identity, and it's a role model for others. But I think there is something to be said about having the permission to be miserable about the fact.
Yes.
Did I say the right thing there? Yes. Okay. That is the existential perspective I'm taking. Let's just look at it and take it for what it is. Damn difficult to be alive after so much trauma and continued echoing of that trauma. And it will continue to be difficult, but You are here to talk about it, and we're listening. You are alive, and that's what we need.
And don't get me wrong, I'm incredibly grateful to be here.
I know. You don't even have to say that.
I think for all of us, even,
It's okay to be ungrateful as well.
yes.
That's what I'm trying to say.
Sometimes I'm real mad.
Yes. Right? I don't know. Are there others in the room who feel similar to Teresa? Yeah? Hands up? Okay, so you seem to really have pointed at a very important phenomenon there. And maybe Survivor's Guild could be a support group topic to discuss. Because, last word, sorry, and then I'm going to shut up. Survivor's Guild really is one of the topics that often comes with enormous shame and a very strong sense of silencing. I cannot talk about this, because if I do, bad things are going to happen. So I think it would be a really good idea to think about how we can mobilize that conversation and discourse more.
I'm getting the okay. I can ask one last question. But I don't know if it's going to be a simple answer. So I'm probably the longest survivor here. But so for those, so Janeth, when you were speaking and you got emotional, and I would venture to say that anyone who's within their 5 years or 10 years get emotional. So I'm 22 years out, and for most days and weeks and months, I forget I ever went through this. But as soon as somebody asks me to talk about it, look, I'm about to cry, I start to cry. And it's like, it's PTSD. Is this a thing, or am I just not normal? Because I'm like, it's been 22 years. I can't get through my story. And so you don't have to, well, I guess what I'm asking is like, am I normal? Is this normal? But what is triggering this emotional?
You're not asking that. I might say what you're asking is actually, have I understood it correctly? And I'm telling you, yes, you have understood it correctly. This is everyone here today who shared a story, shared a deeply traumatizing story. Everyone here in this room. And I think this is the important element. We need to take a trauma-informed approach to talking about these matters. And so it is very important, and I think you're doing an excellent example here with this conference. I just want to also really appreciate this and mention it and acknowledge it. When I came here, the level of professionalism, the level of aesthetic beauty that you generate here for this annual conference, this is trauma-informed care, because you are basically communicating to everyone here in the room, you are important. You are important. And we are going to create a safe space in which we can together be brave. That's what it is, a safe space to be brave together. That's what we need. And then it doesn't matter so much whether you become emotional or not. It is important that you become emotional not because you feel forced to talk, but because it feels right. And I think this differentiation is important to make. So I think your becoming emotional simply expresses that you have a very, very deep scar, which is something most of us here in the room can probably relate to.
So it's not going to go away. I had to put some humor into this. Okay.
Are we done?
Yes, I think they're about to kick us out. So we just want to wrap it up. And I just wanted to say thank you to all the second half of our panelists, Dr. Schultz-Watt, Janeth, Lena, Dr. Ripley, and Dr. Pietra Antonio.